Hello, and welcome to The Two View, the cutting-edge educational show for PAs and nurse practitioners in emergency medicine and urgent care. My name is Mike Sharma. I'm a practicing emergency medicine and urgent care PA in the Dallas, Texas area, and an adjunct professor of PA studies.
Hi, Mike. I'm Martha Roberts. I'm an emergency medicine NP and assistant professor of nursing in Northern California. How is everybody doing?
I'm doing great, and usually this is the two view, but today we happen to have a third view. He is the honorary sunrise view for our podcast. That is PA Carl Chip Lang. Chip, introduce yourself.
Hi, my name is Chip Lang. I'm an emergency medicine PA that practices out of rural Missouri, adjunct faculty for a few PA programs as well. And then I have a business called Practical Pocus where we teach point of care ultrasound all over the country.
Yeah,
Really
Chip,
great course.
I'm unclear. Are you for or against point of care ultrasound? I've not learned this in our many interactions.
Oh, yeah. Well, right now, as you can see, I have my shirt on, so I think I'm pretty pro Pocus here.
Nice.
Just a little bit,
The course is great. I very much enjoyed my time there, and actually it's time for a refresh. So maybe I'll see some of you at the next course, not just Chip, but some of our listeners. Mike, you should come out.
I know, yeah, Martha is an alumna, and I think there's even a video out there of you and Chip getting down on the ultrasound, so that's cool, and yeah, it's a hole in my knowledge I need to fill. Too sweet. Well, at the time of this recording, I am thrilled to be participating in the 2025 National Conference of the American Academy of Emergency Nurse Practitioners. And this time the mountain came to me. The conference is being held right here in Dallas, Texas, less than 20 minutes from my house. It's been great spending some in-person time with emergency NPs and PAs that I've come to know over the years. The original emergency medicine boot camp faculty member, the other Michael Gooch, is one chest practitioner, and I'm looking forward to seeing him, I think, tomorrow. So if you came to the conference, hope you had a great time in Dallas and got some delicious barbecue while you were here.
I love conferences like this. You know, we have a couple of elite, kind of astute clubs that, you know, you got to pay some dues here and there and pay for the course. But honestly, it's just such a wonderful time to network and learn a lot of stuff, even if you've been practicing for a really long time. And one of my favorite conferences, besides our own that we do for the Center for Medical Education and CHIPS, Practical Pocus course, is the BCEN. You know, surprisingly, they put on a really complex show. And don't be fooled because it is, quote, a nursing conference. There are a lot of nurse practitioners and PAs, as well as even some doctors that speak at these courses. And I've spoken a couple times for them at their BCEN Learn Live. It's a small stage, 30-minute TED Talk style course, and their motto is refresh and rewind and renew. So it's kind of like you draw on topics you already know and then refresh those activities and those thoughts while you're at the course. So I love the message all around. Come hang out with some really wonderful people. There's one in Colorado Springs in Colorado, April 29th to May 1st. And then there's one in Destin, Florida in October from the 13th through the 15th.
It's so hard, like, for people, I think, to justify going to a conference because nowadays so many things are distributed and online and asynchronous. But I really do feel like something magical happens when you are away from your home, from all the distractions of home, and you're in a place with other people that are like-minded, that want to learn more about emergency medicine. I really think some learning magic happens in those places. And so, yeah, if you are on the fence, like, you don't have to come to one by CCME. You don't have to go to the one by BCEN or CHIPS Practical Pocus. Like, pick one and go and see for yourself. Do you feel the learning magic happening in that place? And I think you will.
Yeah, I one thing that's great about going away somewhere to learn is if you took that time off from work, hopefully you're not focusing on anything but the course. So when you leave the course in the evening, yeah, you can have a dinner or whatever, but maybe you have some time to actually process the information you've learned, which is a very rare thing that I get to do when I'm home trying to learn.
Instead of coming home and it's like, all right, it's bath time and I've got to feed the dog and whatever else. Yeah, totally.
Right.
Well, it is time for our first segment, the Wet Read, where Martha and I get 60 quick seconds or so to talk about some things that caught our eyes.
Yeah, so first, Mike, I kind of want to talk about this case about a nurse practitioner who was sentenced to 5 years in prison for an $11.2 million disability loan fraud scheme. And I'm referencing a press release from February 5th, 2025, from the United States Attorney Office in the Southern District of New York. And I'm not actually going to use the nurse practitioner's name because I feel like when we use people's names in these court cases, it brings more attention to that specific person when what I really want to do is bring attention to what happened. And so, you know, we're just gonna call her nurse practitioner. And so this nurse practitioner stole the identities of 12 medical doctors and orchestrated a truly harebrained scheme where she used those medical doctors' identity to falsify disabilities for those who did not qualify for relief under the federal total and permanent disability discharge program. And disability program. So basically, she submitted these applications for student loans based on non existent permanent physical and mental disabilities for people. And she had to pay close to her own $600,000 fees as well as serve time in a federal prison.
Mm.
So the nurse practitioner pled guilty. She was arrested. The bottom line here is that the borrowers of these loans were required to have disabilities to qualify. And I wanted to talk about this for two reasons. First, the obvious here is that forging physicians' signatures and submitting fraudulent paperwork is definitely a crime.
So, Martha, this is really interesting just because I do have a little bit of legal experience, mostly because of my wife and then my parents and stuff. But so federal crimes are a really big deal because, first of all, you don't usually get prosecuted unless the federal prosecutor really thinks that they've got a conviction. So to have this investigated, to have this go this far, and then to get the conviction and everything the way it is, it's a really big deal. And the federal system, it's not like the state court. So if you screw up and get convicted in a state court, usually the judge has more leeway, but they have very strict sentencing guidelines at the federal level. So it's one of those things, you don't get the same leeway. You don't get to work out the same deal as maybe you would at a state level. So having this in the federal court system is real bad.
Yeah, I absolutely agree. But there's so many variables here in this case that make what the nurse practitioner did wrong. And the second reason I wanted to bring this to light is because we're often asked to do paperwork for patients and sometimes put comments on that paperwork when we're in the department. And as nurse practitioners, we have to, and PAs, we have to be, and doctors, extremely careful about patients who come into the ED or urgent care with occupational health questions, disability paperwork, or the, intent to sue another party with your supporting documentation. So as someone who's worked a little bit now on some of these med legal cases, every single word, punctuation, and signature will be highlighted in a big screen in any case that comes to the courts. And if a patient comes in and asks you to give them long-term paperwork for disability or time off from work, say that's kind of out of your scope of practice. You definitely can give people a work note. Hey, I give people a week's worth of, time, if I give a reason why, they can't get a doctor's appointment until Friday and, it's now Tuesday and they don't want to go back until Monday, that's fine. But a lot of times registration will just throw this paperwork in front of me and half of it's already filled out. And I need to make sure that I go through all of it to ensure that what's written on the paper is actually truly what reflects my exam and correlates with my findings. I use limited amount of language. I ensure that I place a photograph of anything that talks about abuse, injury, dismemberment, whatever in the chart, because I have Haiku, which uploads to Epic. And one last thing I want to highlight is that if the physician signs your chart in this case, they should really see the patient. They shouldn't just be, I attest to your chart or I attest to your note. They should come and see the patient. In this case, the more the merrier. I know that the physician may not feel that way, but just be careful what you're writing, signing, putting into motion in your department. And, be careful of those long-term disability things, especially like hyperemesis in pregnancy. Get the GYN to write that because that's like a serious reimbursement. I went through it myself with a pregnancy. And, we have occupational health and patients should be directed to follow up with those resources.
You have to decide right now as you're listening how you're going to handle these patients because they are going to pull on the heartstrings and we all have these instincts to want to try to help, right? It's like, I'm here for help. I'm having a serious medical issue. Can't you just fill out this piece of paper? That's why I came here to the ER, for you to fill out this piece of paper. What's wrong with you? Can't you see I'm suffering? I think you do have to kind of make a policy now and as hard as it can be to be like, look, I'm seeing you for this brief period in time. I don't have any visibility on how this has been for you or how it's going to be. So I'm sorry. I just don't sign those kind of papers here in the emergency department. It sounds cruel, but it really is representative of the part we have to play in this patient's care, which is just a sliver of their time. By the way, just so you know that we're playing favorites, we also have for you in the show notes a press release from the U.S. Attorney's Office in the District of New Hampshire in late 2024 about a PA who pled guilty to one count of conspiracy to defraud Medicare to the tune of $7.3 million. Apparently, it is not okay to order genetic testing for cancer for thousands of patients via telemedicine without medical necessity. Good to know. I have updated my plans for next week accordingly.
So the notes from these cases and for our show and every show we've done can be found on our website, and that's 2view.fireside.fm. That's the number 2view.fireside.fm.
Speaking of show notes, you can go all the way back to episode 41 to hear about how important tourniquets can be when applied to the point of care, not just in military settings, but also in civilian trauma at the point of injury. We have for you a retrospective, observational, single-center study published in December 2024 out of Israel, talking about the downsides of tourniquet application, and I thought it was important to put it in context. The main results are kind of eye-catching. The study looked back, and it's 84 patients who had tourniquets applied in the field and were admitted to the hospital. A little under 25% of these patients had complications that were determined to be related to the application of the tourniquet and not the inciting trauma. The most common one was local infection, a little over 1 in 10 of all the casualties, and compartment syndrome, which was just under 4% of all the casualties, to include the ones that were admitted, the ones that had complications or not. So overall, 84. 1 in 10, 1 in 25. When you look at those numbers like that, I feel like it does put these findings in a little more context. And the authors indicate the importance of context in the title of their publication, which is The Cost of Saving Lives. And that's really the stakes we're playing with when we're dealing with tourniquet-worthy injuries. Multiple studies have suggested worse outcomes if tourniquet application is delayed until hospital arrival. If the patient is bleeding out from extremity hemorrhage in the field, it's a go for tourniquet time. Don't be concerned about these complications earlier on, because guess what? The patient has to survive to the point that they actually get these complications of infection, of compartment syndrome, of whatever else. My further takeaway: with 1 in 10 patients developing local infections, it's worth considering whether prophylactic antibiotics should be given early in the patient's care if they have a tourniquet-worthy injury, maybe within the first hour or so, like you might for a sepsis alert. It is what we did in Afghanistan when somebody came with a bad boo-boo. We'd be picking something pretty big and nasty to give them, some sort of ertapenem or a moxifloxacin, depending on their PO tolerance and things like that.
Very good. Chip, you keep these tourniquets in your car?
So I actually do, but that's also because I have a surgical bag in my vehicle for EMS. So that's why I have cats and stuff like that. But I do have to say, I'm actually kind of surprised with only 1 in 10 for local infection. Because if you think about it, if this is a bad enough wound that it needs a tourniquet, and given I did not look at the study to see what type of injuries are being described and stuff, but you know, if you think about that, 10% for bad, I'm thinking like big open injury type wounds. You know, that's actually feels kind of low to me, but also to Mike's point, you know, I think translating this into U.S. civilian world, we tend to, I think, use prophylactic antibiotics a little more quickly. And I think there are reasonable options for this, but that's just fascinating for me, just to think about the fact that they make it sound like it's bad, but to Mike's point, like you have to live long enough to have the complications, but 10% for a localized infection really doesn't seem as bad as what it could be.
Yeah, I really should have gone through and seen, did any of those actually get antibiotics when they came in, things like that. So I'll admit, I did not go that deep into the study.
Well, this would be a great topic for a future podcast, and I'm putting it on the list. So noted. So speaking of things on our list, I'm going to plug our upcoming courses here. So we have our emergency medicine acute care courses coming up. The next one is in New Orleans in Louisiana, April 30th to May 3rd, and that's the Jazz and Heritage Festival as well, so you can check that out while you're there for the course. Then there's one in Hilton Head, South Carolina, April 30th to May 3rd. And then we have San Diego, California, June 4th through the 7th. And that is definitely one of my favorites. Great fun place to go, if not for anything but the zoo.
That's pretty impressive. We got East Coast, West Coast, Third Coast. So pick your coast and pick a course. There you go. We've also got farther down the road the original, often imitated, never duplicated emergency medicine boot camp. That will be in lovely Las Vegas, Nevada. This time, it's going to be in November 5th through the 8th with some pre-course days. That's kind of nice, that way that you can go to this course and not worry about like, oh no, this is during my kid's time off. I'm going to be shopping for Christmas presents later on or during that time. So yeah, this is kind of nice to knock this out early and then have the whole rest of your holidays to do what you will with them. So that's a cool concession, November 5th through 8th, 2025. And more details about those and many, many other courses can be found at the website for the Center for Medical Education. That is www.ccme.org. That is www.ccme.org.
All right, so moving on to segment 2. So this is our dry scan where we're going to penetrate a little deeper into 2 other topics. And, Mike, who wants to go first? Do we want to talk about out-of-hospital cardiac arrest or do we want to talk about influenza? I say we go with influenza first. It's a little less severe.
We've talked recently as well about hashtag worst flu season ever this year. It's been pretty nasty. And if it wasn't bad enough, how about influenza-associated acute necrotizing encephalopathy? That is a mouthful and a disgusting mouthful at that. First, let's define what we're talking about. Influenza-associated encephalopathy, or IAE if you're nasty, is a spectrum of neurological syndromes that are triggered by the influenza virus, that humble flu virus of the respiratory tract that leads to a dysregulated host inflammatory response, leading to varying degrees of brain dysfunction, inflammation, or both. So this is not like the flu virus infecting the brain, but more of an over robust inflammatory response, which we've seen sometimes in just random flu patients, which is so terrifying about the flu. As if that wasn't bad enough, in really bad cases, this can lead to necrotizing changes in brain tissue, which can reveal itself, understandably, as neurologic signs or symptoms in patients who decline quite rapidly. That's acute necrotizing encephalopathy.
So, Mike, just a reminder for all of our audience, and I do like to kind of just really truly define what it is we're talking about. You know how much I love the pathophysiology and really understanding what goes behind these illnesses, diseases, and sequelae of the disease. And encephalopathy itself is characterized by this general dysfunction of the brain. And it can affect various aspects of the brain function, including consciousness, cognition, behavior, movement, and it can also be caused by a very wide range of factors. And I think some of them we forget when we have some of these patients come in. So reminders, infections, of course, right off the bat, viral, bacterial, even parasitic infections like our encephalitis meningitis, right? And of course, here the influenza. But our metabolic disorders, so disturbances in electrolyte balances, blood sugar levels, DKA or liver or kidney function issues, intoxication, absolutely, exposure to drugs, poisons, or heavy metals, and of course our ETOH-induced Wernicke's encephalopathy from alcohol withdrawal. Trauma, so trauma, of course, can from head injuries or concussions can cause encephalopathy, as well as chronic conditions like stroke, dementia. And finally, medications, like certain medications. I think some of the biggest ones that we've seen in the past can be high doses of sometimes fluoroquinolones, occasionally some of our more complex chemotherapy drugs. It really just depends. It's still a researched area that I am actually interested in looking into for future episodes. So that might be our next talk as well on medication-induced encephalopathies.
So exposure to heavy metal, you're not talking about an AC/DC concert, is what I'm understanding.
I don't know. It depends. How much headbanging were you doing?
That could be, multifactorial, I suppose.
That's how you got the concussion.
Yeah. Right. So we know these symptoms of encephalopathy can vary. Absolutely. And they may include confusion, disorientation, altered level of consciousness, even seizures, and weakness, paralysis, changes in personality or behavior. And some of these symptoms can come over time slowly, while others, like the ETOH-induced encephalopathy, like Wernicke's we talked about, can hit like a brick. All of a sudden, the patient is ripping at the bed sheets and trying to murder you.
So, in regard to the IAE, at the end of February, the CDC's Morbidity and Mortality Weekly Report noted that there were some case reports of children with influenza this year suffering from this severe form of IAE, including some fatalities from this necrotizing encephalopathy. This is kids with necrotizing tissue in their brain. So, the CDC researchers started digging. Their research suggested that IAE, so influenza-associated encephalopathy, was on average associated with about 9% of pediatric influenza deaths. So not all cases, but deaths specifically between 2010 and 2025. The numbers for this flu season are a little on the high side, with about 13% of pediatric flu deaths associated with IAE. So how would we even diagnose acute necrotizing encephalopathy, much less spell it, and what would we do about it? Well, in addition to the neuro symptoms, these patients can have characteristic symmetric lesions affecting the bilateral thalami, we went there, thalami, and other parts of the brain that can be detected by head CT or MRI. So I know that we are really close hold on imaging kids' brains with ionizing radiation like a CT scan. But with its knowledge, I think you have to at least consider it if you've got somebody, we've all had the flu or seen someone with a flu and they look kind of terrible. But if we're seeing beyond just kind of like feeling like you were hit by a truck, like you get when you have the flu, now we're actually seeing more neuro-specific type signs or symptoms. It might be worth firing up ye old donut of truth. Prompt recognition and intervention are crucial. These patients should be admitted to a neurocritical care ICU, where any sort of increase in intracranial pressure or multi-organ failure can be managed by the right people. Early intervention by antiviral treatment as well is recommended for children at increased risks of influenza-associated complications, although whether antiviral treatment is beneficial for management of IAE specifically is unknown. Notably, one study reported that oseltamivir, aka Tamiflu treatment, was associated with a reduced risk of neuropsychiatric events among patients with influenza, although there are currently no international evidence-based guidelines for standardized clinical management of patients with IAE. Some things that have been used are high-dose pulse methylprednisolone, plasma exchange, therapeutic hypothermia, immune therapy such as gamma globulin, anakinra, and tocilizumab, whatever I call tocilizumab from our COVID-19 days. And this all kind of makes sense, right? We've been talking about how these are inflammatory changes, not a brain bacteria or a virus, but it's from the body, going ham on the immune system. And so anything to calm down the immune system going crazy, I think, is what they're trying for here.
Yeah, and I wanted to just do a little shout out to NIH for their stat pearls and great summaries on specific conditions and disorders that I use all the time for teaching. They're wonderfully evidence-based and they're always a great read. If you want any topic, put it into NIH Library and you're going to get stat pearl. It's going to help you. They also have great articles published on their site with evidence, and I put a link in the liner notes for one specifically that relates to encephalopathy and influenza. So this one particular article that I found that relates to this is a reminder that, in fact, we know that the influenza virus associated with encephalopathy is what we call a biphasic disorder, meaning for the first day the child has symptoms of influenza alone, and then the encephalopathy develops afterwards, oftentimes quite quickly. According to their research, approximately 1 out of 3 children will die because many of them have multi-organ failure and brainstem failure. The other third will survive with neurological sequelae and cerebral atrophy. And finally, the last third will recover with no problems at all. So the chances of actually having a poor outcome from this are pretty high.
Right. So be on the lookout for those neuro signs and symptoms. Take it seriously when the mom or dad, whoever, says that Junior or Jane is acting a little bit weird. And, sometimes what I've done for kids before is, mom or dad describe something that is just kind of bizarre, and you look at the kid and they're fine. I don't have to discharge them right away. Let's just kind
Yeah.
of hang on to them for a little bit. Let's run some basic labs. Let's just keep an eye on them. And maybe sometimes that weird thing that mom and dad saw will represent again while they're there in the ED, and then you can see exactly what they meant.
Right, right. Okay. So let's go on this next topic here. Out of hospital cardiac arrest, but the caveat here is young people. So Mike, you suggested doing a topic this month related to out of hospital cardiac arrest. And apparently, young healthy adults really, they're having these more frequently than I realized, but you always seem to give me the hard stuff, Mike. So this is an article in JAMA in February 2025 by Seng and Kusaka. Excuse me.
Nailed it.
But we'll make sure we spell their name appropriately in the liner notes for you. These two authors remind us that approximately 60% of these patients die before even reaching a hospital. This, of course, is because of presumed sudden cardiac death. And for the approximate 40% who survive to hospitalization, they've been resuscitated after arrest, have a multivariable cause for their complication. And you can imagine the autopsy-based studies on these patients show that many of these patients, up to 70% of them, have some kind of underlying cardiac cause, like an arrhythmic death, which is common in athletes, structural heart disease like coronary artery disease, and even drug overdose, pulmonary embolism, some of these even subarachnoid hemorrhage, seizures, anaphylaxis, and infection. And we know there are a lot of genetic diseases out there like Brugada, prolonged QT syndrome, dilated cardiomyopathies, and our postpartum patients can certainly have cardiomyopathies as well, even weeks, months after they deliver. And they're a little more rare to come by, but they're there.
Yeah, one of the keys to this article was highlighting what do we do when the patients make it to the ED and they are alive or being, worked up? And the answer is all the things. We are testing them for their blood. We're getting a tox screen. We're getting serial EKGs. We've got them on a cardiac monitor in case they are coming in and out of some sort of arrhythmias, chest x-ray, CT them from head to butt, bedside ultrasound. There you go, Chip, to look for things like pericardial tamponade, dissection, hemorrhage. You're doing everything because this is a person who had an out-of-hospital cardiac arrest who should not have apparently had an out-of-hospital cardiac arrest. These are the apparently healthy young adults that this article goes over.
There was another paper, Mike, in Resuscitation from February 2017 that looked at some of the characteristics and outcomes of young adults who suffered an out-of-hospital cardiac arrest. And what's really sad to read, again, is that these are not uncommon in young adults. Specifically, there are traumatic out-of-hospital cardiac arrests occurring most frequently in young adults. They have a really dismal prognosis. And the first arrest rhythms, usually VF, VT, unknown shockable rhythms. Yeah, but their bystander witnessed arrest, and CPR was often given. And when it was, there were more favorable neurological outcomes. And we could talk about a lot of these studies in specific cases. I actually prefer looking at specific case studies of out-of-hospital cardiac arrest than bigger studies, because I want to know what all the little things were that led up to it. I like to dismantle everything and kind of put the pieces together. But studies like this are useful because they help us plan for, preventative things we can do as far as putting defibrillators in places, teaching bystanders CPR and first aid, interventional strategies, improving EMS, and guiding our future research. And most importantly, bringing attention and awareness to the general public that defibrillators don't need to just exist in hospitals. And they save lives. So everywhere I go, whether it's the airport or the grocery store, I always notice where that particular little device is placed, and I keep that in mind. And I highly suggest that if you haven't refreshed your ACLS or BLS, maybe you're an urgent care nurse practitioner, you don't really, are required to do ACLS or, as frequent training and trauma or things like that. But I would still do it, because anybody who's willing to learn should do that.
Chip, you have your hands on all the high-tech stuff. You're practicing emergency medicine at the top of your game here. But when's the last time you put your hands on one of these AEDs?
So actually, it's funny that you mentioned that because Martha, I actually pay really close attention to where that is and if they have a stop the bleed kit there too.
Yes.
Um, and keep in mind that a lot of places it's going to be close to one of the fire extinguishers as well. So usually they're kind of grouped together. But a lot of places also still don't have
Hmm.
it, which is all the more reason why to keep a lookout for it. But uh, as far as me personally using an AED, it's quite rare just because the equipment I have is set up as a defibrillator, as a full cardiac monitor. But um, a lot of the Zoll systems in particular, and I just mentioned that brand just because specifically a lot of EMS and hospital agencies are using this, has an AED mode, right, that you can then turn into manual defibrillation, which is actually really important in cardiac arrest if it's picking up fine VFib as asystole, which is one of the many, many uses of POCUS in cardiac arrest, along with what you alluded to, Mike, was a rush exam, just so you know. So yeah, there's lots of different things that you can do with it. I love the technology here because it does have a big role. But I think the two biggest things that people forget about that's so important is high quality CPR and early defibrillation. And I think sometimes we get almost too much in the tech. And I know that sounds weird coming from me, but we get almost sometimes too much in the tech and forget about just the true basics that really do increase neurologically intact survival.
Yeah. Well, recently I did an in service for my daughter's Girl Scout Troop 2159 here in California. I taught them basic first aid, and part of our discussion was about CPR and knowing where your resources are. So, we all know that 10-year-olds have done pretty amazing things to help save their parents and loved ones. And I also recognize that teaching this to kids can sometimes be a little controversial, and it's a scary and complex conversation to have. But honestly, just teaching children how to call for help, what to look for, what does it look like, where is it, where would you find that defibrillator, or 10-year-olds can perform CPR if there's nobody else around. But most importantly, they can run and go get help. So I think that teaching kids early is really important, and you can definitely train these kids to assist in some part of resuscitation in a way that's not too scary, and they want to learn, they want to help. So this is a great skill to teach.
Yeah, I totally agree. Like at the very least, right? They can recognize, like you can teach them, hey, if someone goes down, you can put your fingers right here, and if they're not breathing, you don't feel anything, don't question it. No adult's going to be mad at you, but you go run for help as fast as you can. You find the nearest adult and you tell them something's wrong with this person or that person. Because I think, a 10-year-old running up to a stranger, we've told them for years, don't talk to strangers. And this is one time it's like, it's actually very important you talk to a stranger as fast as you can.
Yeah.
So I think this is one of those
Yeah.
times where it's like, hey, I'm going to teach you an exception to the stranger rule.
Well, these patients that have out of hospital cardiac arrest, their cases do not go in vain. I just want to say that because there was a kid, a 15-year-old kid that was talked about on Good Morning America just a couple months ago in September of last year, who ran the mile in PE and then went to go do basketball tryouts and just passed out. And bystanders at the school performed CPR, and paramedics came with a defibrillator because there was no defibrillator at the school, which was kind of shocking to me because I felt like, man, we've done such a good job about getting these resources put in place. And, this kid actually did well and survived, but because there was no defibrillator, they made it their mission to not only teach every kid in that high school CPR and first aid and basic response to people who are found down, but they got defibrillators to be placed not just in the school, but in their community. And yeah, stories like this make a big difference. And luckily, in this case, this particular kid named Ryan did well, and he's making a huge difference. So every little bit counts.
None of us talked about
There,
this together beforehand, but I too do look around for the AED when I'm in a new place because, and it sounds to some people like, boy, that's really paranoid, or you must really be kind of like a pessimist. I'm just a realist. Like, you don't
Yeah.
know when you're going to need it. It's better to know than not know.
so Mike, something I'd just add to that too is that uh, this is something that you can also help get as far as resources for AEDs and sought to bleed kits and stuff like that in your schools and other communities and things like that. And the reason that I say that is because there are actually quite a few grants out there and even just private donations through local community charities or organizations that do that. And AEDs are becoming much, much cheaper compared to what they were even about 5 years ago. So it's something that most businesses should be able to afford that, especially if they're public facing, that it'd be a good idea to invest in that.
Now all I need is for the price of tourniquets to come down. Jeez, I feel like I'm having to put out a loan every time I need to restock my tourniquets. Well, lastly, it is our oral contrast segment where we get into all the nooks and crannies of a topic. And I am so excited to talk to you guys about the Pitt. What do we call this segment? Pitt talking, Pitt takes, Pitt or get off the pot, Pittical care. I'm open to suggestions here. Well,
The pinnacle of truth.
I like that too. That's very good. Okay. Well, maybe you don't know, but there is a new cable TV show out there about an emergency department called The Pitt. And the lead of the show is actor Noah Wyle, who plays Dr. Michael Robbie Urvinovich, who is one of the attending emergency medicine physicians at the fictional Pittsburgh Trauma Medical Center. And I don't know about you guys, I grew up watching Noah Wyle on ER back on NBC, and he started out as a third-year medical student, and he became an emergency physician and an attending, because, like, who can blame him? Like, he switched over from surgery to emergency medicine because, of course, you would. And that show started when I was in high school, and it ran for 331 episodes, all the way to the middle of me being in PA school. And Martha and Chip, I don't know about your relationship to ER, the show, but this almost feels like catching up with an old friend that I haven't seen in a while. And now he's been working in the ER, and like me and like you guys, he's seen some stuff, as they say.
Well, Chip, you can go ahead and comment first about, what you think, because I'm still processing the episodes.
So I have to say that I don't have that same relationship, Mike, because I grew up with attorney parents. So we were very much a law and order household. It was not until after I flew the coop that then I was exposed to that. And really, there are so many other shows that I also got to watch, like Code Black or Night Shift or stuff like that. Oh man, so many of them had their moments that were really cringy and really bad. And I have to say that my wife doesn't watch a lot of legal shows, and I don't watch a lot of medical shows because we don't want to like experience work all over again or feel like we're having to critique our work on the screen. But I'll admit that sometimes there's fun things to watch it, and I do remember watching ER some, but I didn't get that same level of experience. I definitely have not watched all 331 episodes. I can assure you that.
I've watched all of the episodes of ER, and I did enjoy the show because I was in training, and I enjoyed doing that. I think the thing that was really nostalgic for me was seeing some of the streets that looked like Philadelphia. Now it's Pittsburgh, but it reminded me so much of Jefferson Hospital, where I did so much work as a young kid. And man, sometimes their waiting time, even years ago, was 24 hours. Like, it was really crazy. And my father worked at Mercy Hospital of Philadelphia. And so, I knew that whole area. So it was a little nostalgic for me to see that in the filming of this. But overall, something weird happened to me that I wanted to tell you guys, and it's kind of strange. I wasn't expecting this, but at the end of the first episode, without spoiling it for anybody that wants to see it, there was one scene where there was like a flashback to COVID. And all of a sudden, he's in all his COVID gear again. And I know this sounds really strange, but I almost disassociated for a second. I couldn't breathe. Like, I felt like I was there again. And I caught my breath and I just started crying. And for both of you, I'm not much of a crier, but I was like, oh my God. And I was like, this is what PTSD feels like. Like, when people say, oh, that's a trigger. Don't trigger me. I'm like, wow. I've actually don't think I've ever experienced that in that way. It was that emotional for me. I just couldn't believe it. So I will say there is a dramatic and emotional part of this show that was hard for me to watch. And like Chip said, it's kind of hard to watch work after you leave work. But I know, Mike, you want to talk about this show for some other reasons, and I think that's good that we get into that.
Can I just piggyback one thing off that? Martha, I had the same issue. I was not expecting a flashback there, and so when they did that, and I realized what was going on, that brought me back to a place that I wasn't ready to go back to quite at that moment, and so that hit in a way that, like, I'm not saying that there needs to be a trigger warning for it, but if someone hasn't watched this yet, just beware that there is a flashback there that is very real feeling. I even have in my notes about the fact that they're proning people in the back.
That's what got me. What got me.
So that was the part where I was like, shit.
Yeah.
Like, and although part of me is like, I don't know how much I can cuss in this
No cussing.
show, sorry.
You got your one. Okay. We're at an R rating already now because of you.
So anyway, these people have like bunny suits, and I wish I had a bunny suit. Like, instead, I'm just like, here's my N100 and praying for the best with, I wasn't trash bag level, but it's close.
Just the devastation. And the beginning scene is literally a physician on the roof of the hospital giving night shift report, like contemplating whether he should live or die, basically. And we don't really know if he's joking, but it certainly seems like he's pretty serious, I think people listening to this, what we've been through, I don't want to sound like that person, like, you don't know what I've been through. But for people that weren't there, I was trying to explain this to my husband. I said, you will never know. And you know what? I'm glad that you don't, honestly.
This is why I wanted to talk about the show and why I think it's so important for people of not to make it so like grandiose, but people of this country to understand right now is that for all those people who grew up watching ER, or they currently watch Grey's Anatomy, or they've watched other shows, I don't know if any of those other shows really accurately capture what goes on in the intervening minutes between patients, right? Like, you'll have like a patient of the week, so to speak. They call it that. That's kind of like the conceit of a lot of these shows. The patient of the week who comes in at minute 1, and by minute 49, the problem is solved and they leave the hospital and it's all good. But this show does a really good job of how these, and there's physicians and there's students and there's nurses, and every single minute of their day. Now, I understand they've kind of like dramatized the episode for effect, but the way the show is set up is that every hour is a real, so to speak, hour in real time. Like that show 24 with Kiefer Sutherland, it's supposed to cover, like, the first episode is 1 hour long. It covers the first hour of this person's shift, and it is, I think, the worst shift of any of us we've been on, compressed into 1 hour. And then the next shift is kind of like the worst shift ever. And so they do kind of slam a lot into each hour. Again, I think for dramatic effect, but it also shows how we have to go from patient to patient to patient. We don't get a mental break. I mean, not to say boohoo, poor us, in the hospitals, but there's just a lot of stress placed on us by a lot of different things. And I don't know, even in patients who, and I'm not minimizing this, but, it's talked about in the show how people will wait 3, 6, 9, 12 hours for care in what looks like a county emergency department. That is understandably traumatizing, but it's not because the people on the inside of the ER are playing cards or doing TikToks. They are so busy that they can't even go take a pee break in one situation for one of the physicians.
Well, what was crazy was the first, 5 minutes, the amount of interruptions that occurred in those conversations, it was beyond accurate. It was like, I literally felt like I was there. And I think the average person watching that show doesn't really truly understand what it's like to be interrupted that many frickin' times when you're trying to do something. I mean, really, if you were to watch episode 1 again, they probably interrupted at least 300 to 400 times. It was insane.
By the way, Martha, I have this EKG if you could look at it right now.
Yeah, okay. But the crazy thing is that the two of you and myself, we do that. Like, we're talking about one thing, then we talk about another thing, and then we talk about the first thing again in the middle with part of the second thing still being intertwined. And it's like, and can I
Yes.
have a banana? Like the person next to you is like, can I have your banana? And like then the phone's ringing. And it's just like a serious, like this happened to me just on shift. Someone was asking me for my banana. The phone was ringing. A patient was in front of me. Then I was like, oh, I got to get the translator. And then someone's like, here's an EKG. All in like 30 seconds, you know? And I just, yeah, but you know what the coolest part was? Is that literally they said the most important person, the captain of the ship, was the charge nurse. And I think that the
Yes.
public doesn't realize, and I love the appreciation that they give to the nursing staff and trusting them, and they're really good people to count on. And you're going to love this. They actually got the right dose of acetaminophen and ibuprofen. 1,000
Yes.
and
Yes.
400. Not 600, 400.
Not 800 either. Not even 800. Yes, 400.
Yeah.
I love that.
I
Yeah.
loved it.
Well,
Who would be proud? Oh my gosh. Our king of pain.
Sergey Motov would love to hear that. Yeah.
Yeah.
I had a small stroke. Sergey would love that. So
So I have to say that, and I know Mike has categories of things he wants to talk about here, and we'll dive into that. But I have to say that I think this show, out of any show that I have watched that's some kind of drama in the ED or crossover or whatever, is the one that I actually feel like I could tell someone, hey, watch this, and this is about the closest to reality you're going to get out of anything you've seen. And for a while, I felt like that towards Code Black. Now, I only saw part of the first season, but I felt like it was dramatized more than it needed to be. But here, other than like what Mike's saying, you're compacting a lot of people's bad days into one season, which is one shift. For most people, we're not going to see it that way. But I think it is a very great way to show someone this is the realities of what a lot of people are facing in a lot of places across the country. And I think for the public is really beneficial in that sense. And I hope it's successful in that regard to give people like a real idea of what's going on behind the scenes, the things that you don't get to see if you're a patient.
yeah, truly. And honestly, Mike, Mike and I have been friends for a long time, and we both struggle with things that we have going on in our personal lives and work. But, the last couple of months, since going back and working more shifts in the ED, I've been extremely agitated and irritated. And I feel like everybody gets agitation and irritation from their job, but the amount of, I don't know what the word is, just what bleeds into the rest of our lives is so enormous that you don't even realize how badly you've been acting. And it's all kind of normal to you because that's your life every day. And you almost feel entitled to it because you're like, you have no idea what kind of shitty day I had. But when you're talking to another emergency clinician, they do know. And they probably had the same shitty day. So this particular past couple of months has been pretty rough for me. And I don't know about you two, but I just go through periods like that where I just totally feel like every day is an agitation.
So I would say that, I think I mentioned it to you both at some point, probably in Las Vegas with our last class. But I'm serious when I say that the best thing for my mental health was dropping to part-time in the ED and going full-time teaching. And don't get me wrong, I enjoy the ED. I enjoy actually taking care of patients and stuff like that. But even the first 5 minutes of the first episode, there's this whole interaction with administration that I've had myself, and I hated it. I hated it, and I think it's a reality there. But realistically, I felt that to the core there, and I can tell you that since dropping down to part time, I don't think I know the number of bridges I go past now on the way to shift and back.
It's like that algorithm, Chip. Like if you draw the straight line going up, where the bottom axis is level of agitation. No, number of shifts picked up in the ED, and then the vertical axis is level of agitation and irritation. Is just a straight up line, direct correlation.
It is.
So fewer is better.
Well, we're not going to go through every single case in the episodes, although frankly, like each one I think has some really interesting teachable moments, but we're not going to do that. What we're going to do is kind of run through some categories of the show, kind of like awards we're handing out to characters and patients for the first 2 episodes. It was a 2-episode premiere, so the first 2 hours representing the first 2 hours of these physicians and students and nurses and techs and security. They're all in there, and patients, the first 2 hours of their shift. So the first category I want to go through is best advice for the real emergency department. Are there any quotes or situations that were things that if I were to give that advice to a new PA or NP, that'd be solid advice coming out of this show?
No 4-factor PCC. Where is it in the clotting cascade? 2, 7,
9 and 10.
9 and 10.
Yeah, that was hardcore, hardcore knowledge testing, right in the middle of the person kind of like being in a bad way.
And protein CNS. Can't forget that.
So I feel like that was hardcore pimping, but at the same time, that was not that different than like being in EMS and getting precepted, because I had some like paramedics who were just absolutely awful towards me and pimped the hell out of me. But I have to tell you, like, asking while you're actively doing compressions questions about that, like, it makes it a lot less stressful later. Just saying. But my advice or my best advice is twofold there. One is actually in the episode. I like how smoothly they talk to the son of one of the patients who is there for a whole different thing, and basically like, hey, we're going to give your mom a pelvic exam, so I assume you don't want to be there for that. And they get to talk to her, and then they get to talk to him, and it's very, very well done. Like, that whole conversation is like a textbook way of how to do that in a way that doesn't set off too many bells and whistles, at least to start with. My second piece of advice, which I watched ahead, it's in the 3rd episode, but it's the most true. Fine. It's the most true. I got to include this, Mike. I'm so sorry. I'm cheating for a second. Go to the bathroom whenever you can. Don't wait.
Yeah.
Because someone will inevitably have some emergency when you have to go.
Yeah.
And I have, do you all in your EDs have, like, do you carry phones with you? Because I intentionally do not. Like, we were given that option, and every single physician, PA and NP, save like 2, refused to carry a phone on them. Because we're like, we're not getting called any more than we absolutely have. If you want me that bad, you can page me. Yeah. But if I'm in the bathroom, I do not want to have to be talking to you while I'm also going to the bathroom. Like, no, you will find me, and I will come out when I am ready.
Just give me 20 seconds to void my bladder, please. 20 seconds to myself.
Another 20 seconds to wash my hands, please. I just need 1 minute. Just 1 minute.
All right. My best advice for the real ER here is if you want people to be happier, don't make them wait for 12 hours. Okay, like we are so under the gun here, and I think that we may get to this later on, but there is a really intense conversation between Noah Wiley's character and hospital admin, and it's literally going on in the middle of a double trauma alert, and you have the administrator literally waiting on the periphery of the trauma bay to have this discussion with the chief, as far as I can tell, the chief of the ED, and I was just like, oh man, this really seems heightened for dramatic effect. They really wanted to force this into the first episode. And it was good. And it was all legit, where there was this discussion back and forth between administration and the ED as far as the hospital's problems are made to be the ED's problems, even though they shouldn't be the ED's to solve. And so that was just really difficult to watch. It felt a little bit forced, but the conversation had to be at some point. I think they were trying to hook people who actually work in medicine with that. And I was hooked. They got me.
I agree that conversation, when I saw that, I was just like, this is real life here. And then there's the best part is there's even more than just the one interaction.
Yeah, like so much interaction. It's really like, I felt frustrated. I felt like contact frustration. I'm like watching that discussion go on.
Yes.
All right. How about this? The Black Pearl Award for the person who is secretly the worst physician. Okay, now keep in mind, these are all fictional physicians. These are not actual people. I'm not bagging on the actual actress or actor or any other physicians that I might see out there, but there are a couple of really egregious things early on in these 2 episodes that I thought, like, this, like, these were actually bad decisions that this physician made, and they would be worth talking to that physician about later on. Chip, do you have any thoughts on Secretly the Worst Doctor?
Actually, I was going to let you
Okay,
go
well,
first on this one.
mine is for Dr. Heather Collins. So Heather Collins is one of the senior residents. She's the one that wears the maroon, kind of like zip up, not hoodie, but it's like kind of a sweatsuit with a zip up. So there were a couple of things. So first, all of the first episode, first thing is there's someone who has a degloving injury. So basically, the skin of that person's leg was flayed off of the leg, and this person is in truly 10 out of 10 pain. They are howling like a wounded animal, and the surgeon on call is at bedside very quickly, so like props to that for being on rapid recall. And the surgeon's like, can you please give this person some pain medication? And Dr. Collins's character, okay, he's a fictional character, but Heather Collins says, don't give her morphine. It could cloud her mental status. And I'm like, I'm almost certain the 10 out of 10 pain causing her to scream like a banshee is already somewhat clouding her mental status. That's just me, though. Okay, so part of me was like, just go ahead and push the fentanyl. If it's so bad, it'll wear off in a few moments, but give them some respite from this ridiculous pain they're in. So that's number one. I didn't like that because, look, give them pain medicine, and then maybe they can talk to you like a more of a sane human being now that their pain is at least partially controlled. The second one is when you had a patient who was going into VFib arrest, in and out of VFib arrest, and to the show's credit, they were reciting EKG changes that were textbook, almost to a fault, but textbook EKG changes that go along with hyperkalemia. And as we all know, what do you want to at least consider when somebody's like that? You want to push calcium early. You don't wait for the labs to come back. You don't wait for the person to arrest a third time. You push calcium early to the theory is, and I know there's more to it. Don't at me if you're listening to this and you know the advanced science here, but at least the going theory broadly is to, quote, stabilize the heart. Okay. And so you have Noah Wally's character about to push the calcium gluconate, and this Heather Collins is like, just wait 2 minutes for the labs to come back. If they have hypercalcemia, it could kill them. Okay, there are EKG changes that go along with hypercalcemia. They were not the EKG changes that were on the patient's EKG. They had already arrested twice in the span of 2 minutes. This person already is circling the drain and with increasing velocity. So yeah, I think it's time for the calcium gluconate. I don't think it's time to wait on the lab. So that was me. Secretly the Worst Doctor Ever is Heather Collins. But Chip and Martha, do you have any thoughts there?
So I'll pick that up. And I don't disagree. Those are two pretty bad ones. I have to say I did not realize that the Black Pearl Award was being awarded to a specific person. I thought it was just the not so great calls. But I would actually also give Trinity Santos. I think she is also in the running for that. Less about her actual clinical acumen, more about her attitude, which affects everyone around her, and that is a big thing. She gets a separate award from me here in a second, but. Because again, I did not know that this award would go that way. However, I would say that my funny but also still true advice that shouldn't be followed is we don't shock Sicily. Because they didn't use POCUS to see if it was fine VFib. If they had just done they used ultrasound so much. I was so happy. Yeah. I was so happy, Mike. I saw all the ultrasound. I thought this was great. The one time that they didn't do it, and seriously, out of every patient that we saw, the one time they didn't do it was the cardiac arrest. They're like, oh, same dude had gallstones. That was good enough for us. I'm like, no one looked at his heart. No one. He's been arrested. He's down dead. But no one's going to do the ultrasound. Come on. So that was my funny but true. We could have at least used the ultrasound once, even for confirmation or something of cardiac standstill. But I was disappointed there.
I noticed that too, and I felt bad for you.
Yeah. I know we don't have a ton of time left on the show, but my only other comment on some of that is that the surgeons are definitely kind of labeled as mean and rude. But they're not all mean and rude, but a large percentage of them are. But there are some surgeons that I work with, and I believe that character that does a lot of the teaching, like we get this on Tuesday and the ER gets this on Wednesdays, right? They divide up their procedures between consultants. And that's the thing in my hospital too. On Mondays it's ortho, on Tuesdays it's hand, for the hand cases. But I think that a lot of the biases and stereotypical stuff that they put in there are good to bring to light in not just the personality characters of the patients, but of the people that work in the ED. So yeah, surgeons, they're busy and sometimes rude. ER doctors, they make kind of inappropriate jokes in front of patients. Like people still do that, and that's a bad thing. And we do work on not doing that. Or we don't give pain medication when we should in a patient that we might be judging for something like the sickle cell patient who's really in an acute pain crisis, acute chest syndrome. So overall, I give a big thumbs up to the accuracy of portraying those biases, the ones we have both as clinicians and that we think about the patient that goes to the ER.
My next category to give out is save it for the M&M conference. And this would be the biggest medical mistake that happened in the first two episodes of The Pitt. I've got one that I've picked out pretty solidly that I could not believe they did on the show. I immediately was like, whoa, that's pretty aggressive. What do you guys think? Anything that jumped out at you?
Do you want to go first there, Martha?
No, yeah, you just go.
So I'm going to say, just because the way the category is phrased here, is that the one that's going to go to Eminem is going to be Mr. Milton, the gallstone guy who ends up going to cardiac arrest. Not because the care was necessarily bad, although there are things we obviously could have done better and stuff like that. But just because the dude died and it's a medical student who's like, that's going to catch flack, and that's going to be... So one of the few episodes of ER I did watch was when they had an Eminem, and it's like a rapid fire, like they're going through all this, like... That was a really good episode, and that feels like a true Eminem. And that's why when the category is phrased like this, I'm like, it may not be the biggest medical mistake, because there are some that are pretty bad out there, but this is the one I'm like, that's the one that's going to go to Eminem. Out of all the ones, like, despite doing worse care in other patients, that's the one that's going to go to Eminem, because yeah, that med student screwed up and they died. Like, but did they really? Like, is that really what we should take out of this lesson? But that's my thought there. So I know that's a different version of what you're going there for, Mike, but that's my rapid fire answer here.
I definitely think it would have gone to Eminem, but I love how it was handled on the show in a lot of ways, because you have this gentleman who is kind of middle-aged and a little bit doughy, and I think he had some like metabolic issues, right? And so they're really working up aggressively for like gallstones because he has abdominal pain. And who points out that, hey, you better do some cardiac testing on this guy, because upper abdominal pain is the same thing as lower chest pain. It isn't the attending. It isn't the senior resident. It's one of the RNs that is walking by and being like, hey, don't forget this and that. And at the very start of the show, I think somebody mentioned already, they said, listen to your nurses, okay? And so that, I think sometimes when we walk into a new ER, we want to kind of show that we are competent. But I think the way we show that we are competent and confident is we're not afraid to listen to outside ideas, even from people who are RNs, who are medics. These are people who have been there and done that at the place before you showed up, and maybe they have some institutional knowledge about how some things have gone in the past, how cases were handled, and so they're suggesting, hey, let's not repeat those mistakes that were previously made. Okay. My save it for the M&M conference is the patient who had the pretty rowdy facial trauma, who had the floating face, the Lafort 3. And so already we know this person has had devastating facial trauma. And this person understandably has a nosebleed. And so what do? They go, it's time for the rhino rocket. And I was like, wait, no. Like, I really thought they were going to shove that thing all the way into this person's cranium. Because we know that one of the contraindications for these rhino rockets, these devices you insert into the nose and open up a balloon, one of the contraindications to putting anything in the nose is you have big facial trauma because you don't know where that thing is going to stop. You don't have that cribriform plate that is intact. And so I was so terrified this person was going to start seizing in front of them from the table because they had tickled this guy's brainstem. But thankfully that didn't happen. They, thank God, stopped this guy's nosebleed with the rhino rocket. Apparently that was the primary thing to do when this person had a detached face.
So I actually did look because I'm like, there's got to be some stupid case study somewhere or something like that, and there is for this. But I agree with you. When I saw it, I'm like, that's not what I would do. I would do a lot of other things before I'd do that. There'd be a lot of other things I'd do before that. But I do love the very cool effect. Now, by the way, I don't think it's Lefort 3. I think it's Lefort 2. I think they miscalled that.
I don't know. Did you look at the CT, Chip?
Well, no, but look at where his face popped up. If it was Lefort 3, it should be across his eyes. He didn't have exophthalmos or anything like that. His face went up. Yeah, it's a Lefort 2, which, by the way, I'm not dropping cannonballs on people's faces. I'm just saying, like, that's how Lefort decided these things. But I think it's Lefort 2 instead of Lefort 3. Just, minor points.
Nice. Okay. Well, we've seen a couple episodes, and we could talk a lot more about these things. But, I, as much as I was excited to talk about this show on the podcast, I also was a little reticent to watch because I really did feel it's like, man, it's like I already work enough at work. I don't want to be working at home and feeling like I'm at work at home. But I think it has been a really interesting way because I work county ER, so do you, Martha. And so this has been a really interesting way to show my wife about how, it is kind of like this. Like, it's not as dramatic, and the cases don't come so aggressively in terms of the high acuity cases, but a lot of the non-medical aspects of the show may be potentially the most realistic of the show. And that's saying something when how realistic the medicine is. I know friend of the podcast, Ken Milne, is also watching along intently, and he's saying that, he's been showing it to his lovely wife, Barb, and letting him know, this is kind of the stuff we go through, not just from a medical expertise basis, but also the moral injury, he dubbed it, involved in taking care of some of these patients when there are a lot of kind of ancillary factors to play. So, in my opinion, a really interesting show. I'm going to watch it all the way through. It's already been picked up for season 2, and so I'm just really curious about where this goes. And speaking of, Martha, it sounds like you were watching along and you had a future prediction about what was going to happen in the show. Are you picking up what the show is putting down? Do you see something happening that you're going to lay some money down here you think is going to happen in future episodes?
I'm just trying to think about what's actually happening in my hospital to tell you that
Not
answer.
Not the same thing.
I would probably be more inclined to watch it if there was a zombie apocalypse somehow incorporated into it, because I am a true horror thriller fan. It's going to be hard for me to stay on board. I'm not going to lie. I did think everything about it was great. But I was telling Chip earlier, I just don't think it's for me. But I do think there's going to be some more drama, because remember, in things like Grey's Anatomy and even ER, they focused more on personal stories. I think that they're going to go there. I think they're going to focus on, who's the baby, belong to father-wise? Does that father even know? Or who's dating, and who's, why does she have the ankle bracelet on, and like all these different things. I think that we'll find more out about the characters, and that's the real life part of it. Forget about the ER. These are still people that they're trying to show in a drama series, and that might bring me a little more interest. So I think it's going to go more towards people and their characters, like evolving, and more flashbacks probably.
Yeah, I'll let you know. I'll let you know if we get into more character drama. Chip, any future predictions? Do you see any storylines heading in certain directions?
More death, more chaos, and the triage just keeps building up the patients. I think those are pretty safe predictions there.
They're going to open up a tent outside of the ER and start putting patients out there in overflow?
Yeah, I mean...
So they're just going to have patients share beds at this point.
Right. Your head goes here, and his head will go on the other side of the bed. Okay, that way it'll be good. My prediction, and this is, I don't mean to bang on the character of Heather Collins. I think the baby daddy of Heather Collins is Dr. Mike Robbie Ravinovich. That's who I think
Probably.
is the father.
Probably.
And maybe everyone's like, no, duh. But like, that's something that I thought of. That could be what's going on there.
Yeah. Well, if anything, I hope that this show produces more doctors and nurses and advanced level clinicians. And if anything, I hope the public gets inspired by it. Like there are people out there that are like, wow, that young med student, she's 20 years old. Yeah, she's got some nepotism, but you know what? She'll get there on her own. She's smart and she's bright and she'll get there. And I think other people will have that feeling too, that they can make a difference. And I want more doctors. I want more nurses. I mean, please, please.
Well, Martha, it sounds like you had something sweet to talk about as we wrap up.
Oh, I did, Mike, but I'm going to save it because we've already been talking now for an hour and a half. And this is actually a good case that I want to talk about. So stay tuned next month when we dive into this case. And actually, we're going to be talking to, hopefully it's next month, Nancy Denke, toxicology nurse practitioner. So I'm very excited to have her on the show. We'll have more news on that soon.
Well, I'll do my something sweet, and because it is tied to our trivia question from a recent episode here. So, new reports out from the CDC about a sexually transmitted fungal infection. Okay, we had bacteria, we had parasites, we had viruses. Now it's time to complete the quadrifecta, I suppose, and we've got a fungal infection now. Okay, so Trichophyton mentagrophytes, hopefully I'm not mispronouncing that, trichophyton, if you're out there listening, is a fungus that causes ringworm in people and also animals, but a subtype of this fungus, subtype 7, in case you were curious, is one that can be acquired through sexual contact, according to the CDC. There was some discussion about how these cases have now, as of very recently, reached the United States. They were previously more in the European extraction here. But this report published online in June 5th, I think, of 2024 in the journal JAMA Dermatology describes a man in his 30s who developed tinea on his penis, buttocks, and limbs after returning home to New York City from a trip to England, Greece, and California. That's one of the things that doesn't belong, but that's okay, whatever. Genetic tests of fungal samples were collected from the patient's rashes revealed that the infection was caused by the species Trichophyton mentagrophytes type 7. And why would you even do a scraping of ringworm? It's ringworm, treat it with ringworm stuff. The problem is that lesions, infections caused by TM7, as to shorten that here, are very difficult to treat and can take months to clear up, even though they do seem to respond to standard antifungals such as terbinafine. These cases have been more diagnosed in people who are in Europe or traveling to Europe, and as a matter of just fact and not at all judgment, mostly in men who have sex with men. And that is, in fact, the patient who was diagnosed in the case study. The man in the current study said he had sex with multiple male partners during his travels, none of whom reported similar skin issues. So very interesting, and keep that in mind the next time somebody comes to the ED with ringworm in weird places that isn't clearing up like it was supposed to. Well, we do have a winner for last month's two-part trivia question. It was about the fungal STD we just mentioned, and again, that was Trichophyton mentagrophytes, and the winner is Elizabeth Gilly. So Elizabeth Gilly is a nurse practitioner just completing an emergency medicine fellowship. She's about to start her first big person job in an ED. So congratulations on your upcoming graduation, and kudos to you for sticking around and staying in the ED after all that fellowship. I think, Martha, you are muted.
I think it's my first day on the planet, with Zoom and everything. So what I wanted to say was congratulations. And here's our trivia question for this month. We mentioned hypercalcemia as an electrolyte abnormality that could cause arrhythmia. What are the 2 EKG findings that are commonly associated with hypercalcemia?
There's a couple, but name your 2 favorite and email them to us. In addition to anyone else you want to give a shout out to, any feedback and comments about our show, the Pitt, the format, other things we talked about, that's to 2viewcast@gmail.com. That is the number 2viewcast@gmail.com. Well, Chip, we're so happy that you could be here with us and comment on some of these topics and share your thoughts on the Pitt. Any final props, shout outs, plugs you'd like to give?
Yeah, just because you all mentioned the ultrasound course earlier, so we do have at least one course a month in Missouri, but we're actually teaching about 4 to 6 classes a month throughout the country. Most of those are closed courses, so we can come to your institution, teach your people there, as many as you want, or as few as you want. But we go all over, and it's definitely something if you're interested in learning more about point of care ultrasound. We cover just about everything that you can possibly think of. So feel free to check us out, reach out, and hopefully you can come. All of you can come see a course at some point soon.
Are you going to be at AAPA in May?
Yes. Oh shoot. Yeah, I probably should mention. So I'm going to be there pretty much the whole time. I've got multiple talks and multiple workshops and all that good stuff. And if you are a PA student who is listening to the program, you should definitely jump in on the Yes I Scan. Bring a team or bring just yourself. But either way, there are still some openings, so you should jump on that sooner as opposed to later. Hopefully, some of my Missouri students will come join us.
Yeah, there's a really big ultrasound competition for students there, for people to show off their ultrasound knowledge, and there's prizes, and I think, and there's a big competition. It's a really big event. Does Patrick Bafuma run that event, or is he just a big to-do in that event?
So both,
Okay.
I guess. You know, really, he's kind of helped pass the reins on in certain ways, but Patrick is definitely a leading character of that, and he is his baby in many ways. But he has other people who are very actively involved, and I would just like to say that we have like the competitions of being the biggest of its kind in the country, even bigger than like the med student ones. Usually like 400 plus students are attending, so it's nothing small. It's definitely a great learning opportunity, and something that's just cool to watch if nothing else.
We'll put more information about that, the Yes I Scan and AAPA, in our show notes. That's going to be at the website 2view.fireside.fm. Martha, Chip's going to be there. I'm going to be there. What do you think? AAPA in Denver in May. You want to be there too?
I'll think about it. I'll let you know.
Perfect. Well, more information on the original and advanced emergency medicine boot camps, the emergency medicine and acute care course, or any of our courses are available at the Center for Medical Education website. That's www.ccme.org, www.ccme.org.
All right, Mike. That's it for this month's show.
Okay. Well, you can subscribe and rate us on Apple iTunes Podcasts, Google Podcasts. Oh, RIP. It's more now YouTube Music and Spotify. Search for 2View Emergency. That's the number 2View Emergency, and it'll come right up. Ratings help us climb the charts so that other clinicians get some 2View goodness. If you like YouTube and you want to see Martha's puppy walking around and wagging her tail in the background, see Chip's fetching Practical Pocus polo shirt, then you can search for Center for Medical Education on YouTube and catch the video version. Don't forget our website where you can go next level on any of our topics. That is, again, 2view.fireside.fm. Our audio and video engineers are Ricky Bucata and Dave Pett. Show notes are by Meg Dipple.
Thank you again for tuning in, especially Chip. Thanks for being here. And thank you, friends in EM. Share this podcast with a friend. Share your thoughts via email. And thanks again for sharing your time with us today on the 2View. Have a good day and a great shift.